Good morning, everybody. This is the Michael J. Fox Foundation. Thanking everyone for joining today Hot Topics webinar focusing on the role of going beyond dopamine in Parkinson's disease. My name is Maurizio Facheris. I am Associate Director for Research Program here at the Foundation. I am a neurologist in the movement disorder training, specialist by training, and here at the Foundation I oversee most of the clinical portfolio that we fund. Today I am joined by several colleagues here at the Foundation, but most importantly by my co-speaker here, who's Dr. Bloem, and I want to thank him for joining the panel today. Dr. Bastiaan Bloem is a consultant neurologist in the Department of Neurology at Radboud University in the Netherlands. He will be happy, and I will pass it on to a second to him to answer most of the questions, and together with me that you might have during the conversations and during the webinar. Also, I'm really excited to introduce Dave Iverson. Dave is Michael J. Fox Foundation contributor editor and a member of our patient council. And we are very grateful to him because he will be moderating our webinar series. He's been moderating our webinar series this year, and I really appreciate the job that Dave does in keeping the flow and helping us with the webinar and the presentations. Lastly but not last, we would like to really thank Medtronic and Merck for their support of the 2013 Hot Topic series. Just to remind, Merck is also one of the supporters involved in our biomarker study, the PPMI, or Parkinson's Progression Markers Initiative, which is, I think, to date, the most or the biggest study and where the foundation has the most effort so far, both in terms of time and economical support. So we really want to thank all of these players. I am looking forward to this hour together with you guys and to streamline a few of those questions about the mechanisms that go beyond dopamine in Parkinson's disease. And with any further ado, I will turn things over to Dave. Dave, welcome and good morning.
Good morning, Maurizio and Bas as well. Thank you both so much for being part of this conversation, and thanks to all of you who have signed up for this topic. We've had probably one of the largest registrations for this webinar of any that we've done, and I think it speaks to the enormous interest in this particular topic. And it really is, I think, one of the most exciting aspects of Parkinson's research. For so long, we've focused on replacing dopamine in the brain because, of course, that's the neurotransmitter that goes missing in Parkinson's. But as we learn more about the disease, we're learning that we need to go beyond that, and that's what we're going to be focusing on in this particular webinar. And we're going to look at it in two ways, both some non-pharmacological approaches to dealing with Parkinson's, exercise, and a variety of other things that take us beyond dopamine, but then also, as importantly, some new things that are being discovered about other neurotransmitters that are involved in Parkinson's and some new possible treatments in that direction. So we're going to be looking at both of those in this discussion. But let's begin by just having a quick bit of review on how dopamine works within the brain, how that helps us, since that's what goes missing for those of us with Parkinson's, but also what some of the limitations are. And you see on this slide that we focused on that, of course, because that is what goes missing. But that there are some problems with what we do with dopamine, and one of them is hinted at in that first slide. When we take something like levodopa to replace missing dopamine, it helps, of course, but sometimes it can help too much. And Maurizio, describe what that problem is, the problem of dyskinesia.
Right. Yes. So dyskinesia is one of those motor fluctuations that might happen with a long administration of levodopa, carbidopa, which is the gold standard therapy to date for Parkinson's disease. This is not necessarily something that happens to everybody, so I just wanted to remind that. But statistics say that at least within 5, 10, or 20 years after taking levodopa carbidopa, dyskinesia might incur. Dyskinesias are what I call them soft tics, like a small movements of the limbs, arms, legs, or even of the head that might be becoming really disabling in time. And they have two components. One is more a dancing component that we call choreic. The other one is more a rigid spasm that we call dystonia. Sometimes the dystonic component can generate some pain. Therefore, we understand that it's something that is it's still a high priority for us to cure. To really work on. The reason is because the only therapy so far, quote-to-quote therapy, is to control dyskinesia is to reduce the levodopa therapy, like Sinemet or Modopar if you are in Europe, or any other drug that is composed by levodopa carbidopa, and that eventually will turn into a suboptimal control of the motor symptoms of a person with Parkinson's disease. So we do not want that. We realize that is something we don't want, reducing the control of motor symptoms. We want an optimal control of motor symptoms without incurring in dyskinesia, and so we're focusing a lot on that. But that's one of the challenges of just the levodopa therapy.
And one of the other issues, Bloem, with levodopa, as helpful as it is, it's really hard to get a consistent, steady amount in your system. And so we have this problem, as Maurizio was describing, of fluctuations, the so-called on and off cycle. And there are things we can do about that. Sometimes the surgical procedure, deep brain stimulation, can help with that. But if you would just briefly, Bas, describe how that's one of the other issues with dopamine-based therapy, that we're on again and off again.
Right. So initially, most people on the line today will recognize that typically dosing the medication levodopa 3 times a day is pretty much sufficient to keep you stable across the day. Although for almost every patient that I know, afternoons tend to be worse than mornings, and even worse than late evenings. Maybe because people take a bulky lunch, which may interact with the medication, or sometimes maybe because of the fatigue. But certainly afternoons tend to be worse than other parts of the day. But still, 3 times a day, people are pretty much stable across the day. And what you see with increasing disease duration, typically 7 to maybe 8 years, 9 years, is that medication which is initially effective, people can feel that they are ready for their next dose. And usually when patients sense the feeling, it's about time I need to take my medication, that's the phenomenon we call wearing off of the medication. And the troughs in between the effective doses are called off periods. And even though patients can be very good during an on period, their Parkinson's can be very serious in an off stage, and some symptoms can then be much more pronounced, and that can be dangerous. For example, the walking problems, such as freezing, can be okay during the on stage, but suddenly people freeze up when the medication starts to wear off, and this can lead to falls. So that can be dangerous. And the other thing that we now increasingly recognize, as you put in your introduction, Parkinson's is so much more than just the motor symptoms. What we now know is that when the medication wears off in the off stage, not only do the motor symptoms tend to get worse, but the so-called non-motor symptoms may also get worse. For example, mood. People may feel happy when the medication is working fine, feel more sad or even depressed when the medication wears off. Pain, for example, may be worse in an off period and get better when the medication is doing a better job. So both the motor and the non-motor symptoms can fluctuate with the effectiveness of medication.
So that takes us right into the next thing we want to go through, which is Bas suggests all of these other symptoms that all of us know are part of this condition now and that aren't responsive to dopamine treatment. So we basically have two problems going on. One, dopamine treatments have limitations. They can spur these extra movements that Maurizio was describing. It's not consistent, so you have the off and on that Bas was describing. And then there are all these other symptoms that just aren't responsive to dopamine treatment, and this will lead us into what we can do about these. But let's begin with this we've described the motor fluctuations and dyskinesias that take place, but if we move counterclockwise and we see gait and instability, and Bas Bloem, say something more about that particular problem, because you'd think that has to do. You think of gait and posture as being movement related. Why is it that dopamine isn't helpful with that particular problem?
Well, there's two possible explanations. What we know now is that Parkinson's disease in the early stages, in the first years of the disease, is very much a dopaminergic disease. So the loss of dopaminergic producing cells in the substantia nigra is responsible for most of the symptoms that people are experiencing. As the disease gets worse, there are two problems. One, the dopamine deficit is becoming greater, so it becomes more difficult to overcome the dopaminergic deficit, and sometimes the price of a higher dose is the side effects that Maurizio was talking about. And it seems that the threshold to improve gait and balance is higher than it is for example, the loss of dexterity in the hands. But a second reason, which is probably the more important reason, is that with longer disease duration, the damage in the brain begins to extend beyond the substantia nigra in the brainstem, and other so-called non-dopaminergic systems in the brain also become involved in the disease process, and symptoms related to these lesions outside the substantia nigra typically include the gait and the balance problems. So some of those are what we call non-dopaminergic problems, and therefore do not respond well, or sometimes not at all, to dopaminergic medication.
And again, in a moment, we'll start talking about some of the ways that we can get at some of these other problems. But if we look on the other side of this slide, Maurizio, and we also see things where it's listed as autonomic dysfunction, things like bladder problems or constipation, again, problems that are not responsive to dopamine and may even take place very, very early on, even before some of the motor symptoms manifest themselves. So again, this is an indicator that this is a disease that is acting out, if you will, in all parts of the body.
Yes. So, I read an article, and I like to report a quote from Dr. Tony Liang in Toronto, and he says that we should move out, like the Ptolemaic belief, that the Earth was at the center of the universe and everything was moving around the Earth, and now we realize that actually we are moving around in the universe, and the center, like the Earth, is not the center. Well, the same thing happened with Parkinson's. So at the beginning, to your point, Dave, and to what Bas actually said before, the pathology of Parkinson's disease was at the beginning thought to be only in the substantia nigra. But what we learned in the last few years is that sometimes even before motor symptoms appear or after the motor symptoms appears, other areas in the brain are affected. And that involves not only dopamine, as Bas was saying, but also other neurotransmitters that are like small molecules that make neurons talk to each other. And obviously, if the pathology is involving not only the substantia nigra, which is the most responsible for the production of dopamine, but it goes in other areas, other neurotransmitters are also involved in Parkinson's. And that causes, and one of the things that is not only in the brain in terms of the brain, but is all central nervous system. So it might actually getting into the periphery and involve other structures like the control of the heart, and the way that we control the blood pressure, for example, or the control of the bladder, and that involves the challenges with incontinence of urgency that are sometimes frequently presented in people with Parkinson's disease. So is that what we call autonomic dysfunction? As you will appreciate, autonomic is just because we have very little control over those systems. Our system that autonomically respond to stimuli, so we do not have to adjust blood pressure, we don't have control over adjusting blood pressure, or at least a little partially control. But I mean, it's not something that we can, control. The same thing, with the bladder. I mean, we have a little control, but not once we need to go, we need to go. So all these kind of things are autonomically, they are autonomous responsive. And in this case, we start having challenges because the nerves that are talking to these specific organs are somehow impaired as well. Might generate from the brain, might be in the periphery, something that we're learning right now, but definitely speaks to the fact that it's not only degeneration of the substantia nigra and therefore not only involvement of a dopamine as a neurotransmitter.
So one of the things I think about with all of this is that with Parkinson's today, it's sort of a bad news, good news situation. The bad news is that there's a lot going on that goes beyond just replacing the dopamine supply, as we've been describing, as both Bas and Maurizio have been describing. The good news, potentially, is that means that there are a lot of ways that we can get at this, that there are a lot of sort of paths up the mountain as we proceed. And that's what we want to move into now. What are some of the ways that we might address some of these non-dopamine-based problems that happen in Parkinson's disease? So for the rest of our time here, what we want to do is talk about some of those options, things like exercise, occupational therapy, speech therapy, some things that are under investigation but we don't have a lot of evidence about yet, including diet, perhaps acupuncture, new ways of multidisciplinary approaches to dealing with the disease. All of those things are things that are part of that. And then we're also going to talk about some of the additional neurotransmitters and different chemicals that are involved in the brain, and that opening up some new targets to deal with all of these problems that we've been discussing. So we're going to kind of hop back and forth between these two areas, sort of non-pharmacological approaches like exercise, and then also these other approaches that are involved in the various approaches to the disease. So let's go back and start in with our non-pharmacological therapies, and start us out, Bas Bloem, because you've done so much interesting work in this, with the idea of exercise, so that when we think about these various problems that we're experiencing that are not dopaminergically based, what are some of the things that exercise, that we know right now that exercise can be helpful with?
Sure. So I'm a great believer in exercise. I'm a great believer in the non-pharmacological approach of Parkinson's disease alongside with the good drugs that are out there. And I just want to emphasize and underscore what you said. Parkinson's can be a complex disease, but I think the good news for the folks on the line is there is a lot of hope, because the fact that we now realize and appreciate that these problems are there, and the evidence that's beginning to grow fast for better treatments for these areas is definitely giving a new perspective and a better outlook for people affected by this disease. Just wanted to say that to all the people on the line. Exercise is one of the interesting developments. It's important to say what you mean by exercise. Exercise can be two things if you read the literature. One is doing certain practices to improve, for example, gait or balance. The other type of exercise is an aerobic workout, working up a big sweat, increasing your heart rate, and both are probably good for people with Parkinson's disease. To begin with the latter, I think it is extremely important for people with Parkinson's disease to remain active. Sitting quietly in the corner is devastating. Of course, you need to move safely, because if you move more, the risk that you might fall could increase. This is why we always recommend to do exercises under the guidance of an experienced physiotherapist, or maybe a sports instructor, but at least somebody who understands the intricacies of the disease. It's important to exercise at least 3 times a week, probably at about 70% of your maximum heart rate. So you don't need to wear yourself completely down. Working at a moderate exercise level for about 45 minutes 3 times a week is good for you. And by saying good, I mean to say it can suppress or relieve the motor symptoms, so the slowness and the stiffness may feel better. People can initially feel a little bit more fatigued immediately after the exercise, but it may lead to better symptom control in the long run. Whether or not exercise is also helpful to improve thinking and mood, for example, I personally think it does, but the jury is a little bit out there because we need to get a better evidence. And Dave, I'm not sure if this is the right moment to already say this, but there is hope, but no evidence yet. It's important to emphasize it's hope, but no proof that perhaps intensive exercise might help to slow down the progression of the disease. Again, it's a hope. We need proof that this is really the case. So for those people that are considering exercise, do it for all the good reasons, but I cannot promise you it will slow down the progression of the disease yet, although I think it is one of the avenues that might be used to achieve this.
And just to underline the point, of course, the current therapies we all take, various kinds of drugs, don't slow down the progression of the disease either. They help with symptoms, but the disease continues to progress. And what we know about exercise so far, Bas, is that it can help with some symptoms, and it may, underline may, also actually slow down the progression of the disease. We have a number of questions coming in, and I should encourage all of you to post your questions, and we'll get to as many of those as we can. So let me just pose one that's come up so far, and you touched on this, but maybe you can add a little more detail. One person writes in, do we know what kind of exercise is the most beneficial? Is it cardiovascular? Is it yoga? Is it spinning? You know something about bicycling and Parkinson's, Bas. Do you have any specific recommendations about what we know is the most useful?
Yeah, no, the question is excellent. So again, there are multiple types of exercise. One type is the aerobic exercise, the working up a sweat bit. That is the 3 times a week, 70% of the maximum heart rate. And you can test this guided by a physiotherapist. So that's one type of exercise. Another type of exercise is, for example, Tai Chi, a martial arts method to practice balance. And good research has shown that, in fact, the balance and the overall motor symptoms of people with Parkinson's disease were better using Tai Chi than those doing simple stretching exercises. And a third type is really to have an experienced physiotherapist look at your specific gait problem or the specific problem you might have in rolling over in bed or to rise from a chair, because for all those 3 types of problems, there are specific tricks which I reckon among the exercises that can help you to improve your walking pattern, safety of moving, safety of transfers, rising from a chair or getting out of bed or rolling over in bed. So a whole different menu of exercises, and for all of those there is increasing evidence that it's good for people with Parkinson's.
And one other question.
This is Maurizio. Dave.
Yeah.
Can I just jump in for a second? So just like a quick question for you as well, like on my side, like here at the foundation, we always recommend exercise. We've been doing a little bit of research. We've been supporting a little bit of research as well on exercise, and I 100% agree with what you just said. We have anecdotal experience, and as well as a physician myself before, I mean, it's like that exercising is something absolutely useful. We are learning a lot about that proof that you were talking of, looking for neurotrophic factors and potential changes, chemical changes in the brain after exercise. But one of the things that we are not, basically, to answer the question that Dave was posing before, we do not say there is any specific exercise that wins over other exercises. I think, and this is the question to you, I think the way that I understood from your answer is that we have different categories of exercise, like aerobic exercise, which is good in general for endorphins and for a general benefit, and more like a balance focused exercises. But I just want to, and that's my recommendation, I would not like to, for folks to think that Tai Chi would be better than yoga if anybody who's doing yoga right now feels there is some sort of benefit. I mean, they don't need to switch to Tai Chi. I mean, that's my point. I mean, as long as, to your point before, there is a constant like doing 2 to 3 weeks a week, 2 to 3 times a week with 45 minutes, something like that, or at least a constant exercise. So I would not recommend people to war off on something absolutely that they, we basically, I would say I don't think we should endorse any specific exercise over others, because exercise, period, as a category has been proven efficacious in Parkinson's. Would you agree with that?
No, it's a very valuable comment, Maurizio, and I completely agree. The only point I was trying to make is nothing replaces an aerobic exercise. So if you feel yoga is good, please don't switch to Tai Chi. I completely agree, but yoga does not replace aerobic exercise. So
Correct.
I think there is the aerobic part, which is important, and how you do it, I don't care. You can do volleyball, basketball, jogging. I couldn't care less, but do something aerobic and do something that's good for your balance. But
let me raise another question that comes in from one of our participants, because this will also carry us back to some things on the pharmacological side that I want to introduce as well. Jackie raises the question, does exercise cause me to burn dopamine faster? So it's a fascinating question, Bas, and maybe you can say something about what we know, or if we know anything about the interaction between exercise and what's going on with dopamine in our brains, or for that matter, the other drugs that we take.
I have to say I'm very happy with this question, because I think, if anything, the opposite is true. So I hear many people who are afraid to exercise because they are maybe worried that they burn up their dopamine, so they pay a price in the long run. As I pointed out earlier, immediately after the exercise, you may feel more fatigued or worn out, because exercise does consume temporarily dopamine while you're doing the exercise, but it's definitely not deleterious in the long run. There is evidence which I think is totally exciting, but it's in mice, and of course mice are no human beings, but if you intensively exercise a mouse with an experimental form of Parkinsonism, then if you look at the brain after 6 months of intensive exercise, you see the dopaminergic system sprouting, you see the dopamine receptors where the dopamine needs to exert its effects, increase in density and sensitivity. So the brain responds in a favorable way to chronic exercise, and certainly not in an adverse way. So please don't be worried about exercise. The only word of caution is don't overdo it. And I have 2 anecdotes of patients who started to engage in almost weekly marathons, or a patient who started to cycle every day for miles and miles and miles a day, and they deteriorated. That's 2 observations, which is definitely not proof, but it suggests to me that just moderate exercise is fine. Don't overdo it. That's the only word of caution. But otherwise, don't be afraid to exercise.
We're going to jump to some of the interesting aspects of this on the pharmacological side in a moment. But since you're speaking of patient concerns, Bas, why don't you address one other while we're on this subject, which is the worry about falls. A number of people have commented on the short podcast feature that you and I did a few weeks ago, worrying about falls and whether or not if they start in with an exercise program that's going to make them that's going to increase the danger of falling, which of course is a concern with anyone, especially later on in the disease course. So could you comment on that, please?
Sure. Anybody who's watching the World Series right now, and I'm sure most of you are, knows that falling is a disease of active people, of sportsmen. So the more active you become, the more falling you will see. So this is why if you consider to exercise, and I hope after this session everybody's convinced and persuaded to start exercising, is to consult an experienced therapist to give you a regime that is safe for your amount of disability. And one example of a safe form of exercise is a home trainer. Cycling on a stationary bicycle at home at least will prevent you from falling. And I'm not saying a home trainer, a stationary bicycle is the superior way to exercise. It's just an example of a safe intervention. So speak to your therapist and consider any type of intervention that matches your abilities and also that matches your interest in the long term, because we do know that people tend to lose interest in exercise. This is irrespective of whether you have Parkinson's or just any other condition or healthy. You need to have an attractive menu of exercises. So make sure it's a varied menu of exercises.
Okay, we're going to come back to exercise and occupational therapy and other things over the course of our next half hour as we field all of your questions. But I want to integrate into our conversation some other interesting aspects of what we are beginning to learn about Parkinson's. Just as we're learning that there are all these symptoms that aren't responsive to dopamine, that are part of the disease, just as we're learning that exercise can be helpful, we're also learning that there are these other neurotransmitters at work besides dopamine that give us some new targets and new treatment possibilities. Some of these affecting the motor parts of the disease, as we see on this list, some of them affecting the non-motor aspects of the disease. And we see here two columns of other chemicals and neurotransmitters involved. And Maurizio, let me ask you about one in particular, because it relates to what we were just talking about, the concern about falls and balance. And we've heard something from Bas about what exercise can promote in that area. But we also know that the neurotransmitter, the chemical acetylcholine, has something to do with balance as well, right? And so can you tell us what we're learning about that and briefly what treatment possibilities that might open up?
Sure. I mean, here, and to your point, Dave, we get into a little bit more complex, although I think the folks online appreciated what even Bas said before, that when pathology involves different areas, like other potential neurotransmitter might be involved. You talked about acetylcholine, and acetylcholine is definitely something that is involved in Parkinson's disease as well. What we learned, though, is that acetylcholine seems to be involved in the control of the peripheral systems, including like the autonomic system that we were talking before. I can make a very quick correlation to gait and falls just by saying that most likely everybody has experienced, whether they have Parkinson's or not. When you suddenly stand up from a chair or from a lay position from staying in bed, and then you quickly stand up, a lot of people might just experience like a blurry vision, seeing like dark with little like light spots and everything. Those are signs of the blood pressure going down, right? And it takes a few seconds and everything goes back to normal. But in people with problems with the autonomic function, so that for example, that adjustment, it takes way longer. And so one of the challenges that we face in Parkinson's disease as well is that there's control of the pressure when you stand up that we call orthostatic hypotension, so a lower blood pressure when you stand up, is contributing, for example, to falls or to just a problem in that specific case, just when you're walking or just making sudden changes in your position. So it is true, and again, we learned a lot before about exercising and increasing our sense of balance, but we realized that some of those challenges like falling, for example, or the freezing of gait are not responsive to levodopa. And learning a little bit about these other neurotransmitters involved might help us address the neurotransmitter which is involved in that specific condition and target it with specific drugs. Now, you said that before, there is more complications but more hope, because once we learn what is the neurotransmitter involved, we can try to target it even better. And drugs working on specific acetylcholine, for example, are in development. They're being already out there for other reasons, but specifically for gait or falls in this case are under study.
And with something like, give us another example, Maurizio, of one of these others that neurotransmitters that are involved, where a treatment may be coming along soon. Is there something on this list of other neurotransmitters where a new treatment option is being developed that might get at some of these so difficult to treat symptoms?
Sure. So I can make another connection to the talk that we had before about the effect of exercise, and Bas mentioned how exercise can also affect positively mood, right? And what we're learning in Parkinson's is that that not only there's a problem of motors, but there's also a challenge in the mood and depression and anxiety. And what we learn, and that's something that we've been knowing for a while, but in Parkinson's is becoming more and more evident, is that serotonin plays an important role in affecting mood, affecting anxiety, affecting depression, etc. The funny thing about serotonin is the receptors for serotonin are widely distributed in the brain, and there are several receptors. So we get into the complicated field here, but each of those receptors is located in a different area of the brain and might have a different function. And if you notice from the list of the neurotransmitters for motor and non-motor, serotonin comes both, in the motor, in the motor area and in the non-motor area. The non-motor might be what we just said, helping with depression and anxiety and mood disorders, types of sleep cycles, sleep-wake cycles are also affected by serotonin changes. But also, serotonin might be helpful in controlling dyskinesias. And here we circle back to what we said before. Dyskinesias, we heard that are complications of levodopa therapy, but what we learned about serotonin receptors is now widely accepted that serotonin is also controlling the way that dopamine is released in the brain. So now we put this connection, this thing together, and we understand why maybe people with dyskinesia might also have depression, and it is true there might be a problem, might be two different problems, but also we know that working on serotonin and understanding serotonin and improving therapies that are targeting different serotonin receptors might actually benefit both non-motor and motor areas.
So if we take that point and we go back once more to our previous slide, and Bas, pick up the story from there in terms of what we know about other non-pharmacological approaches that could help with some of the things that if there's a new drug that might help working on the serotonin area in terms of whether it's it's sleep or cognition or mood. What do we know about non-pharmacological therapies, be that exercise or something else, that could also help with sleep or mood or cognition?
Yeah. The evidence to support the interventions there is still relatively weak, and this is only because it's early days. We're only beginning to recognize the added value of non-pharmacological interventions in these areas. Although the good news is, even here, we are gaining rapidly more experience. For example, exercise that we mentioned before. We know not just from Parkinson's, but also just from general elderly people who have difficulty sleeping. Exercise is one of the interventions that has proven efficacy to improve quality of sleep. Exercise is in general an effective intervention to improve mood. So for those depressed people, becoming and staying active is also important. In terms of the cognition, again, in the specific field of Parkinson's, relatively little research, but we know that in the elderly in general, participating in exercise helps to slow down development of cognitive impairment, and it helps to prevent dementia in elderly people in general. And there is all the reason to think that the same would apply to people with Parkinson's disease. And a fourth area that I might like to briefly touch upon is the important role of occupational therapy. One of the elements that disturbs the thinking process in Parkinson's disease is how to plan and organize your day. I think many folks on the line will recognize that taking the initiative, drawing a plan, and executing the plan is becoming more rusty, quote unquote. And occupational therapists are very skilled in sitting down with the patient and with the family and to say, look, what does your day look like? What are the obstacles that you encounter? And develop a new program. Typically smaller tasks in a row rather than one big complex task simultaneously. So splitting up complex events into smaller digestible portions, guided by an occupational therapist. So those are just examples of how non-pharmacological approaches can also help to treat the symptoms related to non-dopaminergic areas in the brain.
And let's get to more of your questions that you've posted. Lots of questions coming in, and let's take our final 15 or 20 minutes to try to answer as many of those as we can. You said a moment ago, Bas, the digestible portion. So we have a number of questions coming in about diet. Do you recommend any diet? Can you talk some about diet and about what is known? And those last three words, what is known, are really important because, as you see on our slide here, it says approaches still under investigation, and we list diet as something where people always ask this question: should I eat blueberries? What is it that I should eat? And the truth is, we still don't know much that's definitive about that. Is that right, Bas?
That is absolutely true. There's little definitive, but having said that, I dare to say that I'm a very experienced clinician, and the approach of Parkinson's is incomplete without addressing diet, period. It is really crucial for various reasons. One, people with Parkinson's disease tend to lose weight in the course of the disease. And by itself, losing weight is not so bad because you need to carry less pounds around, so that's okay. But if you lose weight too rapidly, that needs to be addressed. More importantly, because people don't eat enough, they might run into food deficiencies, and particularly vitamin deficiencies. And that's too bad, because Parkinson's is not good for you in its own right. But if you then run into nutritional deficiencies, that's a shame. So make sure that your diet is healthy and it contains all the healthy bits. And if you're uncertain yourself, consult a dietitian. And the third portion...
But is the general rule that what we should eat when we have Parkinson's is not really a lot different than what should be what a healthy diet would consist of for anyone? There aren't special things that need to be done?
No, there are two special things. One is proteins. most people with Parkinson's will end up being treated with levodopa, and levodopa is an amino acid, and proteins in your diet are digested into amino acids themselves. So if you take your levodopa with a protein-rich meal, your levodopa will typically be less effective because of competition in the stomach and the gut. So while on the one hand it is important to keep eating proteins, it is important to spread it across the day and to avoid high protein-rich meals simultaneously with your levodopa. And sort of the rule of thumb is to take your medication either an hour before or an hour after the meal, and not with the meals, even though oftentimes pharmacists will tell you to do so. The other thing you addressed is there any type of food that might change the course of my disease? And you mentioned blackberries as an example. There is, again, very exciting research in rodents, in mice and rats, to suggest that, the darker, the more colorful the fruit, the better it is. But I don't think there's any evidence specifically for people with Parkinson's to do this. Same applies to coenzyme Q, for example, which is widely advertised, but formally there is no evidence to suggest that such supplements really change the course of the disease. But the protein bit is crucial.
And Maurizio, anything you want to add on the coenzyme Q10? That's a question that someone else has raised about the benefits. There've been various studies, but to date there hasn't been anything that necessarily supports that as a dietary supplement. Is that right?
That's correct, Dave. So the enzyme CoQ10 is an antioxidant. My suggestion, I just like to piggyback on what Bas just said, is when a person is having a complement, like a full diet, various diet, and integrating vegetables and fruits and and vitamins, which is definitely important. All of those nutrients have antioxidant, natural antioxidants. Supplementing with CoQ10 could be a potential surplus of antioxidants. Those are not being 100% proven to reduce the speed of Parkinson's disease, of the progression of the disease. My general recommendation, I don't know if Bas agrees on that, is that it's something that is completely given up to your personal decision. There is no evidence, there's no 100% evidence or proof that that is a disease-modifying agent, but is basically unless to what Bas was saying before, people are eating less or have some nutrient deficiency, and then a complete multivitamin supplementation would be recommended.
A question about herbal supplements or multivitamins. Bas, any thoughts?
Right.
No, so if people take the regular healthy diet that applies to all of us, there is no need for vitamin supplements.
I agree.
Of course, unless your GP or your neurologist does a test and shows that you actually have an actual vitamin deficiency, so you can save a lot of money there, I would think.
And what about any herbal supplements beyond multivitamins?
There is one that I would like to address in particular, and that's Mucuna pruriens. I'm not sure if it's very popular in Holland. It's an Ayurvedic herbal compound, which people think, well, this is a plant, this is a natural product, but it actually contains levodopa, which I think is highly fascinating. So this is a natural bean that contains levodopa. Now, the thing is, I'm totally supportive of any intervention that patients feel helps treat their symptoms. But it's good to point out that there is very limited research on these Ayurvedic beans, on the Mucuna. Although one study showed it was as good as the regular levodopa, the problem is you never know how much levodopa is in the jar that you're buying at the pharmacist. Not sure. I mean, in Holland it's available as an over-the-counter medication, which I think is incredible because it's real levodopa. But I do have people who benefit from Mucuna. So that's an interesting one. But people need to realize they're taking actual levodopa.
Maurizio, anything you want to comment on in terms of availability and cautionary thoughts?
Yes. So one thing that I would just like follow up on that, you might have heard of me. I'm Italian as well. So I used to in Italy is also Mucuna is available, and like Bas, I don't have any problems like having people taking it. One of the recommendations would be talk to your neurologist or to your movement disorder specialist if you take it. Like, don't hide it. Just because, to Bas's point, is a herbal supplement of levodopa, and if a neurologist thinks that you're taking a certain amount of, what is the pharmacologically proven levodopa, like Cinemat, or, I think the neurologist should know what is your current regimen, not to get into an extra dose of like a levodopa or an underdose of levodopa. So in general, I have, again, like as Bas said, not a problem. If it's beneficial for a person, that person could keep on taking it. Is available over the counter. It's spelled Mucuna, is Mucuna. Prudence, I forgot how actually is the second part of that, but I mean, you will find it very easily on the internet. And
thank you for well, that's a great point to make sure you and that's generally true, that you want to let your neurologist know everything you're doing, the full menu of what you're engaged in. There's no benefit in withholding any of that information, and thank you also for spelling it because that's also very helpful. Let's get to a couple of other questions. A number of people are interested, Bas, in commenting on one other thing you have up on the slide here, which is the value of speech therapy. And one person wants to know particularly about the efficacy of the LSVT BIG program. That's the Lee Silverman Big and Loud program that has to do with both physical movement but also vocal therapy. Could you talk about what we know about that, please? Sure,
yeah. So out of all the many non-pharmacological interventions that are out there, and just to remind folks, there are 19 professional disciplines outside neurology that can add benefit to the lives of people with Parkinson's disease. 19. The two of those that are best demonstrated include physiotherapy that we talked about before and speech and language therapy. But not just any type of intervention. And the LSVT treatment, the big treatment, is one of the best scientifically underpinned interventions outside pharmacotherapy for Parkinson's disease. So this is a treatment for which there is both a good evidence base and a lot of experience now in clinical practice. The one caveat, well, there's two things to add. One is it's a very intensive treatment, and you need to follow the whole treatment regime. Don't think you can go to a speech and language therapist, receive education once and be done. So it's a fairly intensive program, and stick to the program. The other challenge is many people with Parkinson's disease, there's fascinating research in this area, don't experience their voice as being soft. So they think their speech is okay, but the spouse or any other person in the environment will tell you you're speaking too softly. So you need to be consciously aware of maintaining whatever the speech and language therapist trained you to do, to keep applying it day in, day out. And oftentimes the spouse becomes the reminder to alert the patient that they need to speak up and reuse whatever they trained with the therapist.
And Maurizio, is there anything that you can add on what's going on inside the brain with the voice? That's something else that's not responsive to dopamine. I'm just curious briefly if there's anything happening on the chemical side or the treatment side of this problem with voice that, in addition to speech therapy, is there anything else that we could do pharmacologically that would be helpful on the vocal side of things?
Well, Dave, that's quite a question. I'm actually not aware of any specific biochemical modification in the brain that is involved in or can help improving the voice or the speech in general. What I know though is that we very quickly mentioned deep brain stimulation, and we know of deep brain stimulation being now pretty widely used therapy and effective therapy, but is again a therapy that works only for those individuals that have a response to levodopa. So is a symptomatic therapy. And what we learned with DBS is that sometimes if the electrode is not exactly in the target, a potential side effect of DBS is reducing completely the willing of speech. So like people get what they call anarthria, they don't want to speak anymore, or they shut down, and they don't, both a little bit for mood issues or just because it's affecting the motor function of the speech. But that I think is more of a side effect, and there is no real, I'm not aware of, and maybe Bas is, of any specific pharmacological treatment for voice or speech.
Let me just touch on two other quick things because we're almost out of time. A number of people, Bas, want to know what we know about acupuncture. Could you just briefly comment on that too, please?
Yeah, sure. No scientific evidence for acupuncture. So if people do decide to take acupuncture and they improve, I'm all the more happy for them, but I will not prescribe acupuncture myself because it's not been studied and there's no scientific basis.
Great. And I'm just going to skip back to our one slide here, Maurizio, for a last comment for you of these various neurotransmitter alternatives that are now being studied. Just give us one last thought, if you would, please, about something on the list here that you think has some real prospects for being turned into a treatment that would be helpful to people with Parkinson's sometime, hopefully, in the relatively near future.
Sure. Very quickly, two words, glutamate and serotonin. We mentioned that before. We touched base on the challenges of developing levodopa-induced dyskinesias. Both neurotransmitters, glutamate and serotonin, seems to actively regulate either dopamine or the onset in general of dyskinesia, and there are active therapeutic development programs the pharmaceutical companies are right now exploring, and they are like, if you are familiar with the clinical phases of trials, are in phase 2B, meaning that they're close to the last human testing before getting into the market. So we talked a lot before about hope. We're learning, it's getting complicated, but I think there is a lot of advancement in that specific area, and learning a little bit more about serotonin and glutamate and the way that we can target those specific receptors might help in motor fluctuations in the future.
And finally, Bas Bloem, just a last thought from you as well. If you can kind of put all of this together, as we began our discussion, we talked about the limits of dopamine replacement therapy, so helpful in some regards, but it doesn't get at the entirety or the complexity of the disease. We're learning that there are all these other neurotransmitters involved, but we're also learning, as you've so well articulated, that there are many other approaches that are non-pharmacological to treating Parkinson's. So as you look at the whole of the disease, what would you like people to take away from this conversation about how they can best approach the complexity of the condition, what we can do ourselves as patients to try to contend with the complexities that are before us? Right.
Well, that's a huge task to close this session, but I would like to tell people that after you've accepted first of all, I think it is crucial to accept the fact that Parkinson's is there and it's there to stay. So we can't cure the disease, and those people that find the strength to accept the disease are those that fare best in my experience. Second, make sure you find experts who not only understand Parkinson's disease in general, but who understand and fight for your Parkinson's disease. I think every patient has the right, the inborn right, to see experts who fight for their disease, and then to sit down with your therapist and to think that, and your neurologist, and to say, what is my top 3 priorities? people with Parkinson's disease can have multiple symptoms and complaints. What I do with my patients is write down your individual top 3, and whether it be sleep and your gait and your work, or your speech and maybe sex and your diet, I couldn't care less. But write down your top 3, and there are solutions, not always completely helpful, but at least to alleviate and sometimes really fight your individual problems. And it's better to do 3 things right rather than 20 problems a little bit. And this is the approach we take at our center at the Radboud University, and people really like it. And although Parkinson's is a complex disease, thanks to all the new developments, we can really help people to lead a meaningful and active life.
And it sounds like, along with that, Bas, that to lead that active life, you need a holistic approach, one that involves pharmacology, but also non-pharmacological approaches.
Absolutely. So the neurologist, of course, is a crucial part of the treatment approach, but don't just stick with your neurologist. You need at least a Parkinson nurse to coordinate the care and to sit down and look at all the other problems and to decide together with the patient and the spouse and maybe other family members which of the other 19 disciplines could be engaged to help your specific problems. And you rightly put it, it needs to be a holistic approach. And again, to come back to the World Series, the team that's going to win the World Series is not the best individual players, it's the best team. So the other right patients have is not to just have experts, but to demand that the experts work together effectively as a team. So at least they're informed about what the other guy is doing. So you as a patient receive this holistic approach that, Dave, you mentioned so nicely.
And with that, we must bring our conversation to a close. As Bas suggests, we don't have a cure now, although, of course, that is our long-term goal, and the goal that the Fox Foundation is focused on is finding that cure. Until we do, I think the advice that both Maurizio and Bas have provided us with to take that complete and complex view of approaching this disease so that we go up the mountain on many different paths is the way that we will both reach the goals that we all want as patients and as families. So thank you both so much, Bas and Maurizio, for participating in this. Thanks all of you who have dialed in and listened to this conversation. And Maurizio, I'll turn it back to you to wrap things up.
Sure. So actually, thank you very much to both you, Dave, and Bas for the lively conversation. I enjoyed it very much. We had more than 200 questions, so I appreciate your patience. If we were not able to touch on everything, we did our best on this. We invite you to even come and look at our website. We have a section where we try to explain some of those concepts as well. So and we're just looking forward to the next one. So I just want to thank again everybody for joining today. The next webinar will be on November 21st, and that will focus on surgical intervention for Parkinson's disease. So again, visit our website, which is michaeljfox.org/hot topics, and thank you again, and talk to you soon.